Thank you, Tom, for that wonderful and overly kind introduction. We have known each other for many years, and I hope that hope you didn't find anything bad. Hope that seeing my life flash before my eyes like that is not a harbinger of how this talk is going to go over. I'm very honored and humbled to stand before you today as your president. The Western Surgical Association has always been my favorite society, and I very much appreciated the opportunity to serve as your secretary. However, being elected president is a singular honor and a career highlight for me, and it's an honor that I'd like to share with a number of people who've been important to me both in my personal and professional life. First, I'd like to thank the Western Surgical Association presidents under whom I served as secretary: Mike Farnell, Jerry Jerkovich, Ray Yale, Clive Grant, Stephen Stain, and Will Chapman. Thank you all for your kindness, patience, and support over the years. You made being the secretary an almost pleasant job. Next, I want to give special thanks to 3 Western Surgical Association members that I knew from my days at UT Southwestern. The late Irwin Thal, a former member of this organization, was one of the finest human beings that I've ever known, always positive and a great listener. It was an honor to call him my friend. Bob Reed was the best chairman I ever worked for, always supportive, always a friend. We had a great run over 10 years. Past Western Surgical Association President Rick Thurlby has been one of my heroes since he was my senior resident at Parkland. Thanks, Rick, for your friendship and support over the years. I want to thank my late mother, my father, and my 2 sisters for their love and support. And I really appreciate my father and my sister Atlee coming all the way from Chicago on relatively short notice on a long plane flight. And finally, I want to thank publicly 3 men for their loyalty and friendship during 3 very tumultuous years of my life. John, Joe, and Ken, you guys are absolutely spectacular. As many of you know, surgical education has been a career passion of mine. However, considering the fact that 2 of the last 3 presidential addresses have focused on surgical education, I have officially been scooped. I would like instead to focus this morning for the next 35 minutes on an issue that is becoming a major problem for physicians in general and for surgeons in particular, and one that may be of immediate interest to members of the Western Surgical Association. I would like to begin my talk by remembering Dr. Lewis Thomas, an extraordinary man of his time. He was a Harvard Medical School trained general practitioner who rose to many important jobs in the United States, including past dean of NYU Medical School, subsequently Yale Medical School, and ultimately became the president of Memorial Sloan Kettering Institute. Our focus this morning, however, is on his superb writing skills. He was the Atul Gawande of his generation, and he was well recognized for his ability to simplify complex concepts and to catalog great changes in the medical world. Baby boomers in the audience will recall that Dr. Thomas was a regular contributor to the New England Journal of Medicine in a monthly column called Notes of a Biology Watcher. He authored 3 nonfiction books. I recently reread his 3rd book, The Youngest Science, which serves as his autobiography. Dr. Thomas's life spanned the 20th century, and he had a unique opportunity to chronicle the many changes in medicine that occurred during that time. I was once again struck by the description of his father, an early 20th century GP. The elder Dr. Thomas reiterated many times that doctors could do little to alter the course of disease, but they had to be able to offer comfort by the laying on of hands and to explain what was going to happen. This, ladies and gentlemen, is the art of medicine. Even today, we recognize this as the finest sort of palliative care. There is no doubt that much progress has been made in the last 100 years, especially in the realm of infectious disease, just to name one example. Many patients can be offered palliation such as chemotherapy for cancer or endografts for aneurysms, which do not cure the disease, but slow its course or reduce the risk of death. In the final analysis, though, we still have not made much progress in curing the great ills that affect the developed world, such as cancer and atherosclerosis. And we're not able to prevent most birth defects. This means that doctors must still be able to offer comfort by the laying on of hands and by explaining what is going to happen. Sick patients need to be touched, and again, this is the art of medicine. Dr. Thomas's father worked hard. He had an office at home, and after seeing a full day of clinic, he would have dinner and begin making house calls all night long. He napped in a chair. From watching his father and subsequently from his own experience in medical school, the younger Dr. Thomas made the following observations. Even though the doctor of the early 20th century could not do much to alter the course of disease, he was expected to walk in and take over, to stand by until it was over, and to explain what was going to happen. The qualities that made for a successful doctor included intense curiosity, the capacity for affection, and education for the art of prediction. These descriptions of the consummate physician reminded me of the reasons that we all went into medicine. Malcolm Gladwell, another well-known author and prolific writer of Blink, Outliers, David and Goliath, and The Tipping Point, and also a frequent contributor to the New Yorker magazine, characterized the following qualities in a recent interview with Forbes magazine. As physicians, we are committed to helping people. We are grateful for the opportunity. We are proud of our ability to diagnose and treat, and we are inspired by the trust that people put in us. Ladies and gentlemen, we are engaged in a profession, not a business. As documented in a white paper from the American College of Surgeons that appeared in the Journal of the American College of Surgeons in 2003, a profession is characterized by 4 core elements. Those practicing a profession are given the right to have a monopoly over specialized knowledge, to have autonomy with self-regulation. The payback is that the professional must provide altruistic service to individuals in society and is responsible for keeping up his or her knowledge and skills. We as physicians have a solemn contract with society in that we are given the right to considerable autonomy in practice and the privilege of self-regulation. In exchange, we're expected to place the needs of patients above our own and to behave as role models. The physicians of Dr. Thomas's era had great pride in their profession and put great value on public trust. For many generations, the public concept of physicians has included altruism, expertise, patience, and self-sacrifice. The television persona, and Dr. Cogbo is exactly right, I watch television. The television persona of the good Dr. Marcus Welby and his very happy assistants epitomized public sentiment in the 1970s. Well, how are we doing in the second decade of the 21st century? What about the monopoly over specialized knowledge and skills? The senior Dr. Thomas had an extraordinary amount of autonomy with a practice that ranged from delivering babies to setting fractures to performing appendectomies. One can certainly argue that it is impossible to remain competent in every facet of medical care, and that the physician of today, very rightly so, has a much more limited scope of practice. This is due in large part to invention and research. The rapidly evolving technology and explosion of new knowledge that has occurred in surgery just during the last 50 years is nothing less than breathtaking. The progress has been good for patients, and it has defined new specialties that are becoming increasingly separated from general surgery, such as surgical oncology, transplantation, endovascular surgery, and minimally invasive surgery, just to name a few. Although the separation allows for focused training, it has set up some significant competition between specialties where the lines of the monopoly tend to blur. We see competition between colorectal surgeons, general surgeons, and surgical oncologists, between vascular surgeons, cardiologists, and interventional radiologists. And there are many other examples where the monopoly is no longer restricted to a particular domain. The resulting competition breeds ill will between specialties. What about autonomy? This graph is a paper that appeared in JAMA Surgery in 2013. The authors accessed practice information from the AMA master file data and examined the proportion of surgeons who were in solo practice or two-man practice that you can see represented by the gray line, and compared those to those who were employed by hospitals, universities, or large group practices in which they had no ownership, that's represented by the black line here. As you can see, in 2001, there were about 50% of surgeons who were employed. That has increased by 2009 to 68%. The transition to employed status certainly has many benefits, including a secure salary without having to worry about taking on uninsured patients, and having administrative support to deal with paperwork hassles, particularly the insurance game. On the other hand, employed status means loss of autonomy. The job is really not secure, as we have learned from many of our friends who had lost their hospital-based jobs due to hospital realignment. Most important, the employed surgeon accepts administrative oversight by non-physician, business-minded people whose priorities may not be in the best interest of the patient. The burden of administrative paperwork has certainly increased over the last 4 decades. In addition to pre-certifying surgery, filing claims for rendered care, and appealing denials, doctors must document everything they do and a reason for every test they order or operation they perform. Doctors now spend 1/6 of their time doing non-patient paperwork and 1/5 of their time dictating, writing notes, and other non-compensated activities. Compared to Canadian counterparts, U.S. doctors spend 4 times as much money dealing with the payers as any other doctor in Canada. The electronic medical record, of course, has made this even worse. Are we really self-governing? The short answer is no. The concept of self-regulation is eroding. Surgeons are now subject to oversight by hospital administrators who determine the type of online training each of us must complete in order to maintain our credentials. We are also subject to non-scientific patient satisfaction scores, and we're under scrutiny by state medical boards who serve as watchdogs of our practices and issue their own learning requirements. These, of course, vary from state to state. In Texas, for example, physicians must complete 2 hours of ethics training, and in Tennessee, physicians must complete 2 hours of prescribing learning in order to maintain their licensure. Now, the ongoing training requirements are not a small consideration. I recently added up my own CME requirements for Vanderbilt University Medical Center, the Nashville VA Medical Center, the American Board of Surgery Maintenance of Certification, and the Registered Physician in Vascular Interpretation. And as you can see, it came to 68 hours, or more than a week and a half of training that I have to work into my schedule every year. I'm sure that everyone in this audience has a similar story. Do physicians still have pride in the profession? This startling article appeared in the news reporting and opinion website known as the Daily Beast. The piece detailed the widespread unhappiness among physicians as evidenced by a high rate of suicide, among other factors. While the article is laden with hyperbole, and few of us have ever read the Daily Beast, it received a great deal of attention both in the opinion websites as well as in the lay press. Sadly, many of the commentaries came from physicians who supported the piece, especially recent graduates with large educational loans. Does the public trust doctors? Well, the answer is not clear, but the large number of articles in the lay press that call out bad doctors is hard to ignore. Not a week goes by without some article describing doctors exhibiting unprofessional behavior, assault, public intoxication, Medicare fraud, and a host of other shocking behaviors. Perhaps the best assessment of public perception is to go back to the television and look at the television persona of the physician who's currently being presented. Contrast, if you will, the good Dr. Marcus Welby with the recent sitcom Scrubs, in which we see doctors portrayed as idiots who are moody, distractible, and totally fallible. In the series House, the central physician character is angry, depressed, and a reformed alcoholic. What has happened to the public trust that Dr. Thomas valued so highly? The change in public sentiment has not escaped notice from the certifying bodies. A number of formal programs were developed under the guise of maintaining public trust, including NSQIP, Maintenance of Certification, State License Oversight, and the National Practitioners Data Bank, just to name a few. While these programs certainly have merit, they come at a cost to physicians who must now perform more paperwork, take additional training without compensation, and subject themselves to public reporting and potential humiliation. The risk is that the physician will come under greater pressure, need to work harder, have less time for patients, and less time for home life. The personal toll is perhaps the greatest burden of all and leads to an inevitable end. Burnout. Ladies and gentlemen, this is the hidden cost in medicine, and I'm now going to describe how pervasive and destructive it has become in our society. According to the Merriam-Webster Dictionary, there are 2 definitions for burnout. It is a condition of someone who's become physically and emotionally tired after doing a difficult job for a long time. And it is also the time when a jet or rocket engine stops working because there's no more fuel available. Both definitions work. The former is the literal description that many people in the audience recognize in themselves today. And of course, the latter is the figurative description. Burnout is characterized by emotional exhaustion, cynicism, detachment, and a decreased sense of personal accomplishment. It is a normal reaction to chronic overwhelming stress, and it is not considered to be a medical disorder. However, burnout can lead to undesirable behavior and ultimately to mental illness. Burnout is a very serious condition that is known to lead to a number of adverse consequences affecting the quality of medical care and job satisfaction. Burnout has been linked to increased medical errors and increased medical lawsuits. Physicians with burnout are more likely to have substance abuse and manifest disruptive behavior. Burnout is a very likely explanation for much of the bad behavior that has challenged public trust. Intent to leave practice and divorce rates are also higher in burned-out doctors. Burnout is considered to be at one end of a very bad spectrum, bracketed on the other end by suicide. Physicians die by suicide much more frequently than non-physicians, and physician suicide has recently become an urgent issue for many organizations, including the AMA, the ACGME, the Joint Commission, and the Federation of State Licensing Boards. Last year, there were about 400 reported physician suicides. And if you take that number and think about that for a second, it would take more than 3.5 medical school graduating classes just to replace those doctors every year. Physician burnout is becoming a hot topic in many circles, prompting a number of interesting survey studies. These are 4 of the more common validated methods used to measure burnout. There have been many survey studies evaluating the prevalence of burnout in different medical practice scenarios, ranging from pediatrics to palliative care. Most are small or based on data from single institutions, but all have shown a very high burnout prevalence, with a prevalence rate ranging from 30 to 50%. The burnout spectrum does not begin when a surgeon enters practice. The prevalence of depression has been evaluated in interns. In 2010, Sen and colleagues reported a survey study of 740 interns entering residency programs in 2007 and 2008. Participants were surveyed for a major depressive disorder, not just a depressive trend, but for a major depressive disorder, 1 to 2 months before starting the residency, and every 3 months thereafter for a full year. Before internship, 4% met this definition, and then the prevalence jumped to 27% after just 3 months and was sustained for the remainder of the year. Internal medicine had the highest prevalence rate at nearly 50%, but general surgery was up there, tied for second at 13%. The prevalence of burnout in surgery residents was reported in the September issue, just 2 months ago, in the Journal of the American College of Surgeons. The authors performed a national survey of surgery residents from all ACGME accredited surgery programs, and they used 3 burnout scales to assess depersonalization, emotional exhaustion, and a sense of personal accomplishment. Among the 665 residents who returned surveys, 69% met at least one burnout subscale, and 44% met 2 or more. The prevalence of burnout was not significantly different between years of training. What's the prevalence of burnout among practicing surgeons? The American College of Surgeons Governor's Committee on Physician Competency and Health conducted a famous survey in 2008 of the 25,000 members who they had email addresses on file. Nearly 8,000 surveys were completed, and this represented 90% fellows and 10% associate fellows. 40% of the respondents met criteria for burnout, and 30% screened positive for depression. The authors speculated that at least half of these, or at least 15% of all surgeons, have clinically severe depression. 28% had mental quality of life scores that were more than 1/2 standard deviation below population norms. These data show that burnout is highly prevalent and a serious problem among surgeons. A number of factors were independently associated with burnout: younger age, having children, the specific area of specialization that was being practiced, the number of call nights per week, and having compensation depend entirely on billing. Among the specialties at highest risk were trauma, otolaryngology, urology, vascular surgery, and general surgery. Well, how do surgeons compare with physicians in other specialties? The best information comes from the Medscape Physician Lifestyle Report that is based on survey responses from 20,000 U.S. physicians. The 2015 report shows that physicians of all specialties are at risk for burnout and that the problem has reached a critical level. Note that 50% of general surgeons and affiliated specialties met the criteria for burnout in 2015, certainly higher than the 40% in 2007 and 2008. This means that half the people in this room probably meet the criteria for burnout. In a second survey of ACS members performed 2 years later after the first one, the Governor's Committee on Physician Competency and Health focused on factors that prevented burnout, sort of the positive side of the formula. Rates of burnout were lowest among surgeons who actively protected time away with family and friends, took planned vacations, and saw their personal physicians at least once a year. Rates were lowest among surgeons who exercised according to CDC guidelines and those who indicated that they maintained a positive outlook and found meaning in life. Several other practice-related and personal risk factors have been added to the list originally generated by the ACS study. Among practice-related risk factors, conflicts between work and home life stand out as the major contributor. In fact, all other risk factors can be related to the work-home life imbalance. This imbalance stems from many external and internal factors, but 3 are worthy of note. First, the current compensation model is flawed, as there is an overwhelming emphasis on clinical productivity. Fee-for-service is like an addictive drug. The more you do, the more you want, and the more willing you are to stay late and add on cases. The rising student debt only flames the desire for higher compensation and may explain why younger surgeons with more debt are at higher risk for burnout. The net result is that the surgeon spends less time nurturing relationships, leading to stress, and at the worst, to neglect. Is shift work better than open call schedules? Well, the Medscape data would suggest not. Specialties with fixed duty schedules, notably critical care and emergency medicine, were at the top of the list for burnout. These data show that it's just not about the schedule. One issue that is beginning to receive more attention is physicians' emotional well-being. From the first day of internship, surgeons are taught to second-guess themselves and their plans. Surgeons live in a culture of blame cleverly disguised as the Morbidity and Mortality Conference. Here we must accept ultimate responsibility for bad outcomes, even if the cause was systems failure. This leads to rehash of raw emotions associated with the bad outcomes, embarrassment and shame, and a heightened sense of self-doubt, all of which are associated with burnout and depression. We cannot ignore our own humanity. Physicians may not be able to cope with the pain and suffering of their patients. This photograph was taken of an emergency physician who was seen crying across the emergency room where a patient had just died. It was posted on the internet in 2015 and went viral. Probably many of you in this room have seen it. Is physician burnout a 21st century phenomenon, or has it always been with us and we're just now beginning to recognize it? Well, Dr. Thomas's father clearly had many of the risk factors for burnout, including everyday call, long work hours, having children, and having compensation depend entirely on billing. But it is clear from his book that the elder Dr. Thomas did not manifest symptoms of burnout, and this is probably due to the overwhelming influence of positive factors, including finding meaning in work, maintaining a positive attitude, and most importantly, resilience. Psychologists define resilience as the quality that lets some people bounce back from adversity and come back stronger than ever. It is characterized by having a positive attitude, avoiding negative thinking, maintaining realistic optimism, and accepting failure as a form of feedback. According to psychologists, about 30% of it is genetic, but 70% of resilience comes from external factors, suggesting that we can exert control over our own resilience. This is where the solutions to burnout lie. What would Lewis Thomas have done about burnout? First, he would have recognized the problem in his capacity as an institutional leader. Next, he would have convened experts to evaluate the problem and offer suggestions on how to fix it. Then he would have written about it, both as an expose and to offer solutions. What can we ask of institutional leaders, healthcare delivery teams, and ourselves? And what can the Western Surgical Association do? Well, who are the leaders? The list goes well beyond the hospital CEO, COO, CFO, and CMO. It includes department chairs and division heads, many of whom are today in the audience. It also includes residency program directors, board members, and senior partners. In fact, all of us have a stake in helping with this burnout problem. The leadership of many organizations, including the ACS and ACGME, have already devoted energy and resources towards quantifying the problem, but much is left to do. first institutional leaders